Very interesting topic. ECPR is basically providing artificial circulation during cardiopulmonary resuscitation by pumping of the blood from the peripheral venous femoral venous catheter through the oxygenator into the femoral arterial catheter as an alternative to ventilation with oxygen and external cardiac massage. So this is how our ECPR equipment trolley looked like. So we had a cannulator box in which we had everything for the cannula. Then we have the automatic Lucas device, which was actually there to provide CPR while we perform the cannulation. And then you have the arterial and the venous cannulas. Then you have the post-cannulation boxes and the ECMO circuits and all that you need to keep. So basically, what if the patient is having a witnessed cardiac arrest and immediate bystander CPR was there, the rhythm was shockable, there was no major comorbidities, and no major metabolic derangement. Failure of conventional CPR to achieve ROSC with conventional CPR, immediate transfer to ECPR capable hospital, cannulation and establishment of ECMO support and insertion of distal perfusion catheter, immediate investigation and treatment of suspected cause of arrest if it's a cardiac cause, and immediately shift to cath lab. Then post-arrest care, anticoagulation, monitor for any complications and await recovery. So the arrest to ECMO flow time was less than 60 minutes. So this is your ideal scenario. It might not happen in real world, but this is what should happen. So ECMO arrest to ECMO flow time should be less than 60 minutes. Now indication, obviously, common sense, any reversible cause, and the low flow time or the low flow time is less than 5 minutes, and low flow time is less than 100 minutes. Initial shockable rhythm. End-tidal CO2 is good. Age is reasonable, not above 65. Immediate bystander CPR was there, and access to immediate coronary angio, right? So all these indications are satisfied. Favorable criteria, like, if the patient is having a reversible cause, a witnessed arrest, high quality CPR, not, age not more than 70, initial shockable rhythm, signs of life under CPR, reaching hospital in less than 40 minutes, allowing ECMO initiation within 60 minutes. This is very important. And this is actually the favorable criteria where you can actually expect some kind of recovery if you put the patient on ECMO. Unfavorable criteria will be cardiac arrest, which was unwitnessed, and high, very large low flow, no flow time, poor quality CPR, non-shockable rhythm, or the patient is having major comorbidities and obvious clinical signs of irreversible death. So these are all unfavorable criteria. Don't bother for ECPR. Now maintenance, like normal VA ECMO, what we do. But of course, because the patient had a cardiac arrest, so if there was a cardiac cause, do take the patient to cath lab. And if the patient had a massive PE, do consider for a thrombolysis or pulmonary embolectomy. If the patient had a head injury, then do C-spine and all those things. So because it is in addition to normal VA ECMO, you have to also manage the arrest cause. So you have to consider all these things. And of course, if your unit believes in therapeutic hypothermia, go for therapeutic hypothermia. Most of our units are not believing in that anymore. We just believe in active fever prevention. So an assess for neurological recovery after 72 hours of sedation based on clinical neurological examination and other things. So this is how you manage the patient on ECPR. Evidence for ECPR, last slide. The arrest trial was published in Lancet in 2020. Actually, this randomized controlled trial showed that early initiation of ECMO had an impressive 43% survival to hospital discharge for refractory shockable out-of-hospital cardiac arrest. So this is actually pretty good, isn't it? It's an out-of-hospital cardiac arrest study. The numbers were very small, and this was carried out in a center which was very, very highly experienced in ECPR. So it's very difficult to extrapolate those results to other centers, because as Dr. Ansari said, that the learning curve is actually pretty steep. So further randomized control trial is actually being carried out by the Inception trial, and the results will be out soon, and we'll know what the verdict was. But arrest trial actually showed an impressive survival. Cheer 2 trial was also conducted, and that has also showed that, if we chose our patients correctly, And if we actually, manage to follow the Royal Prince Alfred and St. Vincent hospitals, whatever the protocol they are designed, that they saw that very good neurologically, good outcomes were there in patients of cardiac arrest.